Good afternoon, everyone. They're here in person and also online. We're going to run a slightly extended webinar, I guess is the best description, focusing on exploring some of the pathology challenges that we face. We have a number of different presenters, all with a slightly different perspective, which hopefully you'll find interesting. In terms of the way the session will go, each presenter will present for about 30 minutes. And then we'll have some general questions on that presentation. And then at the end, we'll have time for some more general questions. So I'm going to hand over to my, my counterpart, Dr. Charles Gutteridge, who's Chief Clinical Information Officer at Barts Health and works with me as a clinical lead for SNOMED. Over to you, Barbara.
Thanks very much, Ian. Yeah, so I am indeed Charles Gutteridge, and it's very, very good to see you all here. Welcome, and I hope you enjoy this session. I've going to talk for about half an hour, as Ian said, at a high level, I think, about some aspects of pathology in the UK. And a little bit unusually for me, I've put some attributes in. So for those of you who are not English trained, FRCP means I belong to a college of physicians. So although I no longer practice, in fact, don't even have a license to practice, I was once a practicing hematologist. And in order to do that in the UK, you also have to pass a pathology exam. So I'm also a fellow of the Royal College of Pathologists. So there are two attributes which are definitely not standardized globally. They're probably semi-standardized in the UK, and most people who are medically qualified will have an idea what they mean. And then, as you know, the moniker CCIO varies across the world. So some of us are called CMIOs, some are called CCIOs. Now there are a whole group of people who call themselves clinical digital officers and so on. So my point around this is really on my next slide, which is in the late or the early 1900s, Sir Frederick Treves, who was born in Dorset, aged about 55, got on his horse and literally rode round the county of Dorset. And he kept a diary, made maps, and described his journey in this book, Highways and Byways in Dorset. And you can see that his attributes were Bart, which doesn't mean that it might do that he came from Barts Hospital. It means that he's a baronet. And ditto GCVO is an attribute which was of the Grand Cross of the Victorian Order, and so on. So you might be forgiven for asking, what on earth is the good doctor talking about today? And you'll see that underneath, I've put Proteus syndrome and given you a SNOMED ID. And the reason for this is that Frederick Treves actually was medically qualified. He had an FRCS. He was a surgeon. He was a preeminent surgeon and actually performed the first appendicectomy in 1888 in the UK. I don't know if appendicectomies had been done elsewhere, almost certainly, but he performed the first one. And he became super famous in 1903 when he operated on the newly crowned King of England, a bit like our current situation. Queen Victoria died. Edward VII got sick. He had a hard lump in his abdomen, which Frederick Treves judged to be an appendiceal abscess. And I would say very unusual for clinical practice now, what he did was simply on a kitchen table in Buckingham Palace, he operated, made a small hole over the right iliac fossa and drained the abscess. And history apparently relates that the next day the king was sitting up in bed smoking a cigar. Anyway, whatever the surgery did or didn't do, the king survived it, and Frederick Treves ended up being knighted, which is, as you know, how we reward the great and the good in this country. But even next step, Frederick Treves is probably most famous for his work at the London Hospital where I work, for having taken out of a sort of local circus of exhibition the Elephant Man. And he housed the Elephant Man in a room in the top floor of the hospital and looked after him for about 5 years, after which the Elephant Man died. And when I was a medical student there, the Elephant Man's skeleton was one of the skeletons we had available for us to look at in our museum. The skeleton's now disappeared and it's no longer on view because, as you know, the way that we learn anatomy has changed and the way that we deal with human remains and so on has massively changed as well. But there is a point to my story about this and Proteus syndrome, is that approximately, 140 years later, we know a lot about Proteus syndrome. And here it is modeled in SNOMED. It's a really rare condition. And there are maybe 50 cases in the world at any one time. It would be a challenge for any of us to diagnose the condition just by looking at them. Very few people have presented in the same way as the Elephant Man. And the reason for that is that not only is there an underlying genetic disorder, but the underlying genetic disorder is expressed as a mosaic. So only some cells express the gene defect. And so if many of your cells do, then some of the things that are in the model happen. So lumps on the bone, lumps in the skin, lumps on your nerves, and so on. And if it's not deeply expressed, there may be completely asymptomatic people who are never diagnosed. And because it's so rare, it's very unlikely to be discovered. But where I'm going with this is that the model shows that the defect may be a pre-cancerous, or at least a part of the syndrome of conditions that may lead to cancer. And some of that's very well understood and well expressed now. So the gene mutation in Proteus syndrome is actually a mutation of AKT, which produces unbridled growth in the cell that is affected, but usually non-cancerous. But you can see that complex pathway of messenger proteins there. And you'll all, I think, be familiar with the idea that mutations in the RAS gene, or in the RAF gene, or indeed some of those others in those links, are determining factors for cancer development. And that actually now, there's a huge number of drugs which are listed, and you won't be able to see them in that, but which inhibit those messenger proteins and may be transformational in extending the lives of people with cancer. And one of the challenges for a practicing physician like me would be remembering any of that and learning which of those drug inhibitors might be useful in a, oh, so sorry.
Want to use this one? Then you can want it.
I'll stay here. Apologies to those of you online. I was moving around the room, forgetting that I had an audience of thousands online. And just to give you a sense of what the room is like, there are about 30 people with us. So there you go, and I will stop moving about. But the challenge for us as clinicians for putting together a cellular diagnosis from a histologist, the genetic diagnosis from our genome analysis, our clinical observations about the lifestyle that that human being has undertaken and whether there are things that we should intervene there, and putting that together into a single bundle of decisions to help patients survive longer and not to suffer is the challenge for individuals across the world. And this really, really matters, because when you begin to look at the outcome of patients with cancer, it varies substantially from country to country. As you can see here, the UK, by comparison to the other countries in this particular graph, does rather badly. It has too much lung cancer by comparison to other countries, perhaps except Denmark. The mortality is higher than some of the best performing countries. And the net survival at 5 years for lung cancer in the UK is the worst of this group, with, and this was, I think, at 2014, and so the data has improved a bit since then, but the UK was at the bottom of the pile with 5-year survival for all forms of lung cancer at about 15% of all patients presenting with lung cancer. So this is really bad news. And it's set, I think, a whole set of things running where SNOMED has an opportunity to make a difference, but we have not made that happen yet. And let me talk through some of that. So first of all, I think there's a really interesting thing centered on Cancer Research UK, but which is an international benchmarking partnership that involves Australia and the different jurisdictions in Australia, all of Canada and the different jurisdictions of Canada, Denmark, New Zealand, and so on. And it won't escape you that those are all SNOMED member countries. So that's one opportunity to begin to use this collaboration, not only for what they've done, which is to say, do people do badly or well with cancer, but is there something that we might do differently using data? I think that's a big opportunity. That report from the international collaboration had a profound effect, at least in the UK, about what can we do not to be at the bottom of the pile. And some of that was reported in a strategy document with a progress report in 2016. And I would say, sort of reflecting on this, that the emphasis has been on the comparison of outcomes using old style data types and not engaging with modern data technology, and in particular, not engaging particularly in the genetic underlying causes of cancer. And before I go much further, I'd say one of the reasons to get excited is that our friends who are not in the room this afternoon, but have been here all week, is that Scott Campbell and Jim Campbell, and indeed Daniel Carson and others, published a paper in 2018 saying, hey guys, this is how you could do this differently. And we have spent, I suppose, quite a lot of today's meeting trying to understand how we might actually do that at national scale. And I'm going to try and talk you through some of that. Just returning, though, to that question of how data is captured in the UK, the emphasis has always been on what can we do to drive ordinary human beings into the sort of the cancer net earlier, on the thesis that if you identify cancer early, you're going to treat people better and they will have longer survival. It's not a bad thesis, and it's probably true, but all of our instructions from the Department of Health and across the NHS is focus on that bit on the left, on primary care identification of cancer risk by making sure that people engage in screening programs, if there's a screening program for the particular cancer, for improving access to the things that might identify a cancer, and so on. And so that has determined the data set that we collect. And let me take you through that data set, because I think it's a bit of a monster personally. So the focus has been on capturing data about people with cancer and how long they live. And people have written learned papers about how to improve the data set, looking at people with multiple cancers, looking at the data sources and making sure you don't miss patients with cancer, looking at the dates of incidence, looking at making sure that people who appear in one registry but not another actually cross-link and so on. And not surprisingly, that generates an industry of difficultness, I would say, in trying to put all this data together. And this particular report then made a whole set of recommendations about how to improve the data. But I would put it to us as a group, it's the wrong data, guys. We need to think differently about this problem, because we've done this for now something like 20 years, not exactly in this way, and the answer is always the same. We do less well. We're just tracking people's outputs and so on. And there's new discovery to be made doing this differently. Here's the sort of stuff that our groups are focusing on: screen detection, making sure that anybody with a possibility of cancer is seen within 2 weeks, having been referred to hospital by a GP, by making sure that inpatient elective waits are short and people are operated on or treated with radiotherapy and chemotherapy at an early stage, and so on. So that's all great, and it's an important part of the service, particularly for the patient frightened by the possibility of cancer. They must be seen quickly. It's the human thing to do. And here we go. So what's the data set? It's all ICD-10, and it's all clouded in words that I think we feel uncomfortable about. Neoplasms of unspecified nature of the bladder. Now, who is that and what is that? And how shall we use that kind of data? Some of it, of course, is more straightforward than that, but this is probably, again, not the right way to think about data today, particularly if you want to link it to the other features of cancer. This data set is called COSD. It's the cancer outcomes data set. And it's collected in primary care, in secondary care, in a whole range of ways. Some of it comes from a data flow designed by the National Data Registration System. Some comes directly from pathology systems in the UK. And there are other forms of cancer audit that also fill the data set. And this is what it looks like. Can you imagine being in the top row of that and trying to organize all of the data that flows from these different systems? My hospital PAS system, our cancer system that does multidisciplinary team outcomes, the laboratory system, and so on. So not surprisingly, the data set is hard to manage. It's hard to organize. And to be frank, with modern enterprise level record systems, all these data in there is real world data extractable at the point of care. And so I don't know whether to make the plea to you as a group of clinicians to say, stop jigging about with individual systems. Start implementing whole hospital enterprise systems that collect real world data and which you can reuse from the point of care onwards and not create these extraordinarily complex registration systems. I'm going to switch tack a little bit and blame the college that I'm a member of that writes gobbledygook, I would say, about what is required. And here's one that is advice for authors writing the kind of things that Laszlo's been talking about all week, which is, can we create templated forms that automatically collect the data? And my own college gives extraordinary advice, which says it's okay to use SNOMED terms that come from a generation of 20 years ago. And it's still okay because we don't know how to get you all to do something different. And I think that's a bit of a shock, really, and one that we all need to think about a lot. And it sort of gets worse because the latest guidance says it's still okay to do that. So we're now talking about guidance that I think came out in 2021 or around that time, which says, well, we know there's a better version of SNOMED CT with modeled information, which we could use for purpose, for doing better in cancer care, but it's still okay to use SNOMED 2, 3, 3.5, RT, and to report it. So let me show you an example. You may not be able to see this, but you'll get the general gist of what I've got on this slide, which is this is the London Hospital's histology department output to COSD last week. It's only part of it, but each of those lines is a set of topography and morphology codes and procedure codes for patients who have had a cancer diagnosis made for them. And you can see that what we send to COSD is only those codes and doesn't have any CT. The situation on the ground in the hospital is slightly better. So here's an extract of a report that was issued for a patient who presented with postmenopausal bleeding and has carcinoma of the endometrium. And we're beginning to see some of the structured data that we're building into these templates. So is there invasion or not? Yes, no. Is there cerebral clearance? How far is that clearance? 9 millimeters. What's the provisional FIGO stage 1A? Is there a consultant pathologist involved? There is, but I've blocked their name out. And you'll see this individual, driven actually by their own ambition and their own knowledge, is now marking the report with a SNOMED CT code. But I'm slightly embarrassed to tell you, as far as I can tell, she is the only one. So where to go next? Well, first of all, there is better guidance in version 9.1.3 of the COSD, and with some clear statements about moving to integrating modern terminology within COSD. I think there, the issue now is no longer perhaps in the guidance from college or at NHSD level or NHS England level, but is more about, can the vendors do something to help cellular pathologists report in the right way? And I would say, and I think I heard a lot about it this week from all of you, that that is coming. So in my own organization, we're having a very lively conversation with one vendor on developing synoptic reports. You won't be able to see the detail of that slide, but the point is that they have a product that can be used well, used fast, and support enterprise-wide reporting using structured data and producing synoptic reports. Terrific stuff. And it's driven by this phenomenon, the switch from using a microscope to using scanned images of the slide. And you can do amazing things with these scanned images. You can magnify them very fast, shrink them very fast. You can scan a whole image within a few seconds, finding areas of interest, which even using low power in a microscope would have taken minutes, if not sometimes more than minutes, to find an area of interest. And you can measure stuff, you can plot it, and you can turn it into data in the way that this slide illustrates for people interested in nephropathology, but this obviously applies to any kind of cellular pathology. And so the images are up there at the top. You can do all sorts of interesting storage and so on with that. You can use it for sampling individual parts of the slide and doing DNA analysis or omic analysis at individual points on the slide. There are a whole set of things of ways that we can annotate the images as they come through with SNOMED, with free text, with whatever we want, and to use that to derive digital pathology. And obviously there's the ability to demonstrate the images to others in multidisciplinary team meetings and to turn this into the kind of knowledge that would make a difference to patients and their treatment. So I will take us back now to the London Hospital and to Barts, where old Frederick Treves first started, and just say, I think there is stuff going on all over the place, which is about to change the discussion. So here we have a system that has been in play at the Barts Cancer Institute for about 12 years, actually. And where they help individual clinicians match clinical data from the general practitioner, mostly now in SNOMED, data from their own biobank, which is in SNOMED because they use SNOMED to annotate their biobank, our own EHR data, which is all in SNOMED, and now they've made a proposal to start to annotate the genomic data in SNP-Nexus, as they call it, with SNOMED, which they'll author and model with the help of SNOMED International, and to use that to expand the utility of SNP-Nexus, which is, by the way, a free online resource which any of you can log on to and use, and you may well have similar things in your own institutions. And the purpose, obviously, going back to the patient, is to help me select drugs that are likely to be effective. And so this slide just shows us that we have a whole set of genomic biomarkers, and we can work out from the data whether somebody is likely to be resistant to the drug that we have in mind, or to to be sensitive to it. And old style chemotherapy, you put your finger in the air, you tell the patient to lie down, you put something in their vein and you squirted it in, and you waited 2, 3, 4 months to see if there was a response or not. And now you can begin to personalize that decision-making, saying, well, here's the range of drugs we could use. Looking at your molecular pattern, I'm pretty sure you're going to be resistant, so we should try something else. And that's a very, very different discussion to have with a patient than the one, I've sent your data to COSD, and in 5 years' time, I'll tell you whether you're dead or alive or not. So I think this is really, it's on the verge of happening globally and on the verge of happening nationally for us in the UK. So I would leave you with 3 takeaways. The vendors are very close to doing this with us. The opportunities for doing digital pathology, artificial intelligence, machine learning are legion. So if you want to be a really famous person like Sir Frederick Treves, get onto this bandwagon today. If you don't, it's still worth doing because you'll improve the care of your patients. And that's, of course, linked to new discovery about cancer and indeed a whole range of other conditions. So I'm going to stop there. I'll open it up to questions, but I imagine I won't generate too many questions, but let's have a see. Laszlo came first, and then the gentleman in front.
Yes. Shall I just go to the mic?
And also for those of you online, if you have any questions, just pop them in the Q&A box at the bottom of the Zoom screen. Thank you.
Thank you very much, Charles, for this really nice sort of illustration of what is important in pathology. And let me tell you, advance, I will going to disagree with you on one point, which is the vendors. And I'm entitled to change my opinion. Scott told me yesterday that I'm okay now. But my opinion was that we have to wait for the vendors, and they will do it. Unfortunately, this is very few and far in between who are able to do, and you showed sector, they are probably the closest one to solution. But what I think, if we want to make the impact which you were talking about in your presentation, we may not use the vendors because they will have different versions, different things. They will not have version control and anything. And I think we just have to lift up our head a little bit, do a bit of horizon scanning and look at the direction of the Netherlands to PALGA. Because what they have done with the synoptic reporting and cancer data sets, which is the low-hanging fruit in management terms, they created a system by which the vendors they can log on to, create the report inside PALGA and feed it back as an XML blob to the LIMS system. And this is by far the fastest and easiest adaptable for the vendors. And in a way, I still need to agree with you that the vendors would be probably jumping on this bandwagon better if the country and the government would allow us to create a similar system. And one more thing to it as well. The significance of SNOMED CT and SNOMED terminology 2.3 version X. Again, from the example of the XML blob I've seen demonstrated yesterday by Paul, they code everything in SNOMED CT, but also they retain some of the old stuff, the old school SNOMED codes. Why it is important? Because we all have legacy data, as you demonstrated with your hospital. It's good to have that legacy data and link it one way or another. I think these are the things which I'd like to highlight, but I entirely agree with you. Digital pathology is one of the important things to do. And if God forbid, we are enabling our digital pathology with SNOMED CT, metadata, and synoptic reports inside, that is going to even catapult this thing further. Thank you very much.
Thanks very much, Lazo. And I have to say, I don't disagree with you, but I think there's a kind of balance between the innovators like yourself in relatively big or very big institutions with the kind of IT backup that can do this, with smaller departments that will have to depend on vendor systems. So.
Hi, first of all, thank you so much for the inspiring presentation. My question to you, first of all, giving a shout out to SEP, the NHS Clinical Entrepreneur Program. You know, when you mentioned about digital pathology and machine learning, is there also any plan to include maybe digital twin of the cancer tissue to enable pathologists to make better decision making for the patient? Digital twin.
So if I answer the question correctly, this is, could the digital twin type of approach help us get faster towards the correct treatment pathways?
Yes.
Yeah. So I think the answer must be yes. There are examples of that all over, both the business world and obviously the medical world of using digital twins, using that as part of your machine learning programs and so on. So I'd be amazed if that wasn't the case. I'm not aware of anyone doing so, but I bet you there are some scientists somewhere beginning to develop those ideas. So fantastic, and join us. Yeah. You'll need to use the. Well, perhaps I'll let the questioner ask. But in essence, what you're doing is creating a model of a human being, or indeed a business process or whatever, and testing the effect of an intervention using computational methods, and then comparing that to a real person or real process. And over time, you build a set of data that allows you to really tune up your decision support tools.
Hey, Charles. Thank you. Really good talk. I think everything is spot on, and actually seeing vendors do that change that we wanted to see for a long time. Amazing, right? And this is a great opportunity. So I'm an idiot in some ways, I guess. I always think, well, what can we do as a SNOMED community to make this easier, right? And I did this probably 15 years ago. So I'm going to hold up this phone, which everybody can recognize this. And hey, Apple still produces a Android to an iPhone migration assistant. They don't need to. People will still go flock and buy it. Where am I getting at? So what I'm getting at is, I don't know how many of you have looked at the antecedent mappings from SNOMED 2 to 3.5 to SNOMED CT. They are complex. The same code can mean different things across versions, right? Now, I would wear a terminology hat and think I know what these means, but relying on a pathology, digital pathology supplier to be able to implement it and enable this is a difficult challenge, to say the least. So as a community, is there anything that we could do to make that migration easier? Because otherwise we would lose, what, 20 years worth of data also? Again, I'm not asking for solutions, I'm asking for thoughts. Do you think we can do anything?
So in a sense, the simple question is, the simple answer to your question is, yes, there are things. I think all our experience, though, is it's unbelievably hard. And it takes time. I've always been struck, I qualified before some of you were born, I suspect. But I started practice in 1976. Larry Weed, 5 years before me, as a relatively young clinician, talked about the problem list and its importance in creating computational medicine. 70 years on, we're still arguing the toss about whether a problem list is a good thing or not. And I still argue a lot with my clinicians in my institution about doing some problem listing. And I find it really hard to understand why that's so difficult to understand. It's partly about the difficulty of getting data out of a system to drive their change. So I think we are again on the verge of a new world where the data extraction from electronic health records becomes a real thing, and that people can just download stuff in a governed way, but which makes a difference to practice. And I think we're seeing that through the personalized medicine type of initiative. You can't do the decision making by yourself anymore. So I think that's one thing. The next thing is things like this, where we're sharing. But the trouble is, you and me and everybody else in the room all think the same, don't we? So we've got groupthink. We all think it's fantastic. Yeah, let's do it. But we haven't persuaded the literally 5,000 young and old doctors at Barts Health that this is the thing to do. So that seems to me the test for us, is to get ways of sharing this in productive ways that make it possible, and to do it without building too many clicks into whatever solution you have, and all that stuff that I argue endlessly about with the individual clinicians. But I do think it's possible. And I think, as I say, going back to my story about 1975, we're in such a different position now than we were then. And it's a miracle to watch. I was a hematologist. I started out live where most patients with hemophilia came to me with looking like that. And then we killed them with HIV, hepatitis B, and hepatitis C. And we don't do that anymore. Indeed, we can treat them genetically, and they're completely different people. So in one generation, we have made flips in things that were universally fatal or chronic diseases that you simply couldn't treat effectively. And I think that applies in a vast array of the conditions that we're charged to look after. I probably should stop, shouldn't I, Ian? And hand on, or are we?
So we have one question on. Okay, Farzaneh, do you want to ask your question? Just need to press the button on the mic.
Okay, so Farzaneh, do you want to ask your question? I've unmuted you, so you should be able to talk.
Sorry, I didn't have any question. I don't know how it came up as if I wanted to.
You just wanted to wave, that's fine, it's cool. Okay, no
yeah,
worries.
it's probably my laptop doing something
It's
weird.
okay, don't worry.
Sorry about that.
It's okay.
Okay, so we'll give you one further.
We'll give you one question if you're quick.
It's not a question, just a question. In the Royal College of Pathology, all of the reviewed data sets for the last, I think, 3 years or so onwards, and currently should have SNOMED CT codes in them. It's not as bad as you may say that part of the old data sets, they still have old school SNOMED CT, SNOMED code, but the new ones are compulsory to have SNOMED CT, and that's why probably your colleague can do the
Yeah, you're absolutely right. I painted a blacker picture to get, the sense of change going.
So before
Okay,
I have one question for you online before you go walking off. So what are your thoughts about the variety of terms providers use for procedures, specimens, source, etc., impacting the ability of vendors and laboratory professionals on mapping to SNOMED CT accurately?
That's a tough question for me, but I think my view is just the practical one, which is SNOMED CT is good enough, and we should just get on and use it. I've done that since we went live with an electronic health record system in 2008. And the things that have changed is that the vocabulary, the terminology is expanded. I can still access it. We do have some issues, I think, locally about deprecated terms and so on. But it is possible to do good science, to use the real-world data for purpose. And I don't think we should get swallowed up in terminological arguments. We should just get on and do the thing. Okay, no other questions? In which case, it's my pleasure to introduce you to Stan Huff. I'm sure most of you know Stan, who is going to tell us more about LOINC, about the integration or collaboration with SNOMED CT, and some stories about pathology, no doubt, Stan. So welcome. Are you going to stay there? I have a clicker. And your slides are all here. And I think, indeed, if I just press that, I'm... Whoa.
Reloading.
I'll look after you, Stan. This is personalized lecturing. There we go. So it's literally just that
guy. Okay. That's interesting. Well, it's a pleasure to be here, and it's an honor to be with this august panel. I hope I can say something useful. I focus this sort of. I wouldn't have given this to a general audience, a general medical audience. This is tailored to you folks who care about data and modeling and science and the practice of medicine. But let's see here. Okay, so what I'm really going to talk about is interoperability, and that relates directly to challenges that we have. But why, you guys know, so I won't spend a lot of time, but we want to improve care, we want to decrease the cost of care, we want to increase the efficiency of care, help people learn, make providers happy, and make people, customers happier, and ultimately help people live the healthiest lives possible. And that's a shameless steal of the mission of Intermountain Healthcare, where I worked for 37 years. So I want to provide the motivation for why we want to do those things. So this is Eileen, and Eileen is actually a real person. She came to the HL7 meeting in San Antonio in 2012. She came from Singapore. And when she left Singapore, she was in good health, feeling fine. In fact, she had run a half marathon 2 weeks prior to coming to the HL7 meeting. She came to the meetings. She came actually and introduced herself at one meeting, but said she wasn't feeling well, so she went back to her room. The next day, we heard sirens, an ambulance, and we soon had word that she had collapsed in the hall and had been taken by the emergency personnel to the local hospital. And she was there. She was in the emergency room for 5 hours. She had fever, nausea, vomiting, some hypotension, a high lactic acid, and an abnormally low white count. I think her white count was 1. And they knew she was sick, but they didn't know what. They were thinking about tropical diseases because she came from Singapore, so they're thinking dengue fever and other things. And so they admitted her to the floor, and while she was waiting for the hospitalist to come, she went into cardiac arrest. So they immediately instituted resuscitatory measures and moved her to the ICU. She continued to have a downhill course. I was actually called because I happened to know her, and the other people who were with her did not have kind of knowledge of the U.S. healthcare system. And I watched her go downhill and die about 3 o'clock in the morning. She died from septic shock due to untreated group A strep. Yeah, who said that? Oh shit, yeah, exactly. It shouldn't happen. You know, what could have been is that if we had interoperable data, there would have been an algorithm running in the background that would say, hey, you've got a high risk of sepsis. You need to push fluids, you need to draw blood cultures, you need to give antibiotics, you need to, you know, all of the treatment. And she would have survived. Now, as one of my professors in medical school said, you know, one death is a tragedy, and no, yeah, 1 million deaths is a statistic. Well, this is the statistic. So this comes from the British Medical Journal. How appropriate, we're here in London. With a study looking at deaths from preventable medical errors in the United States. So I won't go through all of the numbers. I'll just emphasize one number there. The best estimate is that 250,000 people die of preventable medical errors each year in the United States. Now, some people don't believe that. I believe it. I can tell you why I believe it, but there's certainly been multiple studies that all confirm, and you could, you know, the exactly where we're at, if it's 200,000 or 400,000 or 250,000 varies, but everybody knows that there are a huge number of people who are dying. Now, how can that be? Why? You think about that at a social scale, at a social level, that would, you do a little bit of math, that means that in the United States today, somewhere around 660 people will die from a preventable medical error. Now, these aren't people who are already terminal. These are people who, and you know, they did this by looking at charts and reviewing these are people who would otherwise have had a life expectancy of at least 6 more months or a year. And most of them, or a lot of them, you know, should have lived for another 10 years or 15 years or 20 years. But we're not providing very good care. That's just, and so my experience with Eileen is repeated again and again. And how can that be? I mean, if 2 jetliners crashed every day, that would make the news. That would be front page. But these people are dying in individual hospitals scattered all over the United States in thousands of different hospitals. And so it goes unnoticed. And I think it's, to quote Larry Weed in another way, it's medicine in denial. We're not paying attention to what we're doing. And there's another article in New England Journal of Medicine back in 2003 that said physicians do the right thing approximately 50% of the time. And that's just totally unacceptable, totally unacceptable. So there are a couple of things that we gleaned from that. One, from David Eddy, who said, the complexity of modern medicine exceeds the inherent limitations of the unaided human mind. So that's focusing on the fact that nobody knows everything. Our current paradigm is one where people do primary research, they publish in the medical journals, it eventually gets into textbooks. Physicians read either the journals or the textbooks. They're taught those things in medical school, and then they're expected to remember them. And somewhere we've missed the boat because people can't remember all of that. We accept the computer doing things that that are obvious that we can't do. So we can't remember all of the drug-drug interactions that exist or could occur. There are all kinds of things like that that we allow the computer to help. But somehow we think we're invincible in diagnosis and in treatment. And all of the evidence would say, actually, we're very poor at that. And again, Larry Weed, pointed out that there are roughly 100 causes of chest pain. And the average clinician can tell you the signs and symptoms, can help you distinguish between pleuritic pain and heart pain and musculoskeletal pain, etc. And they won't think about the other 100 things that could cause your chest pain. And so that's, the only reason we do as good as 60% is because common things are common. The 6 things that physicians know that cause chest pain are the common reasons that you have chest pain. But you're just in trouble if you've got one of those other 94 causes of chest pain. But the other thing is also interesting, which is not just limited knowledge. We're not perfect information processors. So we do things wrong even when we know the right thing to do. And it could be, that it's because we've been up all night, we get confused between 2 patients, all kinds of things. But as Clem said, you're just guaranteed that people are going to make errors in their information processing, even when they know. Now, a corollary to that is if you ask people about their knowledge, they'll tell you the right thing. So you ask any physician whether they need to do hand washing and whether they need to do hand washing between patients because they could provide, an infectious vector between the 2 patients. And they all would say, 100% would say, yeah, we learned back with Lister and back 100 years ago, we learned that you need to do hand washing. You watch them and they only do it 30% of the time, okay? So we got a lot to work on. So this isn't my vision only, but there's a vision that SNOMED is involved in directly, and LOINC and those other things. It's a vision related to what was just talked about, that we can take data from our electronic health record systems, we can, from any, from public health, from research, anything. And, using FHIR profiles that are deliberately incorporating LOINC and SNOMED, we can make that data available through a standard API. And that means in that upper right-hand corner, you can make applications that could be an application that detects occult sepsis in the emergency room, or it could be a simple growth chart kind of application, or it could be one of the applications that's shown there is management of neonatal bilirubin. But there are a whole set of things then that we could make programs that would do occult sepsis, community-acquired pneumonia, pulmonary emboli, ICU glucose management, ventilator management, public health reporting. I mean, there's literally a nearly infinite list of things that we could represent as formal knowledge that the computer could then implement. And we get into a scenario where we're sharing knowledge, not by trying to have people read it and then recognize and apply it when they see a particular patient, but have the computer doing that work in the background and then prompting the clinician and having the clinician make judgments as appropriate in addition to that. But it's a different world where we're now sharing data through executable programs rather than through the classical medical school kinds of stuff. And so we want that to be plug and play. We want those things to be something that once it's created, it can be used anywhere. One of the challenges that we've had is that kind of knowledge, that sepsis program. We've had one of those at Intermountain Healthcare for roughly 15 years. And our mortality rate went from 25% deaths, a 25% death rate in people with sepsis in the emergency room down to less than 6%. But one of the challenges is because all of the systems are different and they haven't been standardized, you can't move that application to the next hospital without doing all kinds of remapping, reconfiguration, everything. And it takes, 6 months or a long time to do that. It becomes cost prohibitive. And so even though we have the capability technically and theoretically, we don't do it, can't do it. So what does interoperability look like today? It's awful. So there in the real world, that's meant to be a woman in a laboratory doing a given test, and they're all doing the same test. And what happens today is, whoa, it comes out different from every system. The shape of these things represents, if you will, the structure, whether you're outputting XML or FHIR or version 2 of HL7 or C disk or whatever. And the color represents the terminology. And so the terminology and the other things are different. And we take that data out in the digital world, and then we start trying to use it. And to use it, we have to apply a process to try and standardize it or normalize it. And that process is different each time because of the different structures and the way you do it. And then we end up with data. Now, what you'll notice is that it's not quite the same data. Slightly, it's mostly the same shape, but it's a little different, because transforming data once it's been stored and is not totally technical. You have to worry about how it was collected and a bunch of other things. So we're really working hard. So what we want to do is this, okay? If we could, we would have the data at the source created using standards, and then we don't have to reconvert it for all of the downstream purposes that we have. We don't have to change it to report it to a public health. We don't have to change it if we're participating in a randomized controlled trial. We can just use it and take care of people, and we become a learning health system through that strategy. So what are the challenges? And I'm being sort of following the lead of the first speaker here, a little bit provocative in these things. How can we make lab results truly comparable? We're always learning new things about the situation, context, the metadata that bear on the meaning of the things that we can see and touch. We know, for instance, that methods of analysis are important. Obviously, the units of measure are important, but it may be the analytic device or preconditions, whether the patient was fasting or sitting or standing, if we're getting into clinical data and not just pathology data. And obviously, there are all of these other things, that may be important in interpreting the result with age, sex, race, genetics, all of those things. But we learned, and we'll continue to learn. This isn't the end of where we're going. What we learned during COVID-19 is, you have the instrument that you're using to do the COVID test, but there were rather dramatic differences between who supplied your reagent. Well, kind of the lesson from this is that we need to be careful, and I'll say this in an additional slide as well. We don't want to make LOINC codes that contain, or observation codes within SNOMED that pre-coordinate all of that information into the code. We always want to know the method. We always want to know, the device, any preconditions about fasting, not fasting, etc. Some of that should be in the code because being part of the code means that I quickly recognize that the difference between a random and a fasting glucose. There are other things that we know are going to change all the time in terms of reagents and devices and analytical techniques. Those things should be post-coordinated so that we're not making codes unnecessarily, but we have policies that we agree to that says that data must be shared in the transactions that are shared between systems. So another challenge, and I'm being really kind of practical and mundane here, people choose the wrong code. There are 978 LOINC codes for glucose. And if you pare that down a little bit to serum or plasma glucoses, there are only 650. Now, there are actually good reasons for all of those, because the kind of things that are going on is that they're distinguishing random versus fasting glucoses. And they also are distinguishing between glucoses that are part of a glucose tolerance test versus random glucoses. That sort of thing. And when you pre-coordinate the instruments in, part of the things is whether it was done in a certified laboratory or whether it was done on a home glucometer, etc. But the point is that there are a bunch of codes out there, and what the standards say basically right now is, at least the FHIR standard says, okay, here's an observation resource, and you need to put a LOINC or an observable code there in that resource to say what you were doing, and then here's where the result goes, etc. Well, you all know what's going to happen. You send out 20 people to choose the right code from 650 choices, you're not going to get a high degree of concordance between that. And so there's a need for education. There are a lack of resources to do the mapping. So when they've done studies, you can see that people who are doing the same thing use different codes to represent that as an output. And that doesn't create interoperability. So one of the fun things that's going on is LIVID, which is LOINC codes for in vitro diagnostics. And what they're doing is asking people who create test kits, who create instruments, who create reagents, to say, this is the LOINC code you use. So people now, instead of going out and browsing all of LOINC to figure out what to do, they go, oh, I bought my instrument from Beck and Dickinson. And they say, oh, if I'm measuring sodiums on this kind of sample, that's the LOINC code that I should use. That won't save all of the challenges, but it will create a much better opportunity for us to choose the right code. But one of the things too is, I guess a lesson learned is that we can make perfect concepts and we can create all kinds of elegant ways of defining things if in implementation people can't use it. It's like, further purification of an already pure substance. So we always have to think about implementation and the practical issues related to that. So another challenge is always focusing on what's important. One of my key mentors, Homer Warner, used to say, "There shall be no recreational data collection." And what he meant by that is, just the fact that something was commonly done didn't mean it was something that we needed to do. And that before you made codes for things, before you did anything else, you said, what am I going to do with this? Am I going to make decisions with this? Am I going to provide direct patient care? Or am I going to use this for population statistics? What do I want to decide? Do I want to decide, is this going to be something that I use to decide what therapy to provide, what medication to prescribe? Know what you're doing so that you know what data to collect. And so not all knowledge has the same value. So there are literally an infinite number of relationships and statements of truth that you can make about the universe. Now, there are the vast majority of that infinite set of things that probably don't matter to what we're doing in terms of taking care of patients. It probably doesn't matter what color of socks people were wearing. I don't know, it might come up. But the point is that we have to figure out the set of things that we really care about. And sort of, again, the lesson learned from that is that hierarchies usually only work for a particular use case. So the structure of hierarchies they can be based on physical fact, if you will, but the physical facts you choose to represent in the hierarchies are based on what you're trying to do with the information. A lot of times we try and force things into a single hierarchy, like as if that hierarchy would be perfectly useful for all purposes, and it's just not true. And then there's some things that only happen once or so few times. It's not worth putting them in a hierarchy because we can find them by their name anytime we want to find them, and they're not a part of a group because they only occurred once. So there's some things that just aren't worth making a place for in the hierarchy. You want to name everybody, but you don't have to have a place for them to live that's distinct and fully defined. So another important challenge is making use of shared information models. When we first started creating LOINC back in 1994, one of the key things that we learned was that knowing that we were going to use that code as the observation identifier in the OBX segment of a HL72 message really helped us define the boundaries of what we needed to say. Without thinking too much beyond that, you could say, for instance, we're never going to make Stan Huff's hemoglobin level. It's always going to be a hemoglobin level, and so we focus. We're not going to make codes that mean a stat hemoglobin or a stat hematocrit or a stat glucose level, because we need to express that, but it's expressed in another field in the message. And so not to include that. And so that helps a bunch. And it helps, again, it's not so much directly with just lab data, but you can think of the application to diagnostic data, et cetera. It's incredibly important to know sort of whether the diagnosis you're saying is something that you're trying to rule out, whether it's something that was the admitting diagnosis, whether it's the final diagnosis, whether it's the really final diagnosis at an autopsy, when you finally know the real truth about what happened. But the point is, you can reduce and focus the effort on what codes to make by really understanding where you're going to use the code and how you want to use the code and how you're going to use the information to make somebody better. I'm getting close to the end here. One size doesn't fit all. As Tom Oniki, one of my fellow co-workers, said, medical terminology is about how much you want to pre or post coordinate. And two common use cases that we try and cover are data entry, where people love to pre-coordinate things. They love to just choose one thing to create, to add to a problem list, not click on a bunch of boxes to make a sentence. We actually did experiments that showed when you give them the chance to click on multiple boxes to make sentences, about 10% of the time they make a nonsensical sentence. So you want to do that. The other use case you want to cover, though, is analytics and queries and clinical decision support, where post-coordination, or the most reasonable post-coordination, is much preferred. It simplifies dramatically how you do the calculations and the inferences if you understand the data as post-coordinated parts, and because you can do easy queries to ask, well, did they have a fracture of the hand? And you don't have to have, you know the bones of the hand, and so it's easy to know where they had that as a post-coordinated representation. And so one size doesn't fit all, and the implication of that is you have pre-coordinated things and you have these post-coordinated representations, and you need to map between them, and you need to do it real time to meet all use cases. And so, the SNOMED expression language has been very useful in that, and for representing creating isosemantic representations. And we need to, it should, just like the codes themselves, the mapping of pre-coordinated representations to post-coordinated should become a library of things that everybody in the world can use, because you need to do that in operational systems to make it work and make the work convenient for clinicians. So this is the kind of final thought that I wanted to present. And this is sort of just unrelated to challenges per se, but just thoughts about what we're doing as we use medical data. So at the lowest level, we have things that we can perceive or that we can measure directly through looking at electrical voltages or thermometers or other things. And from those direct perceptions, you can create primitive data. So if, I can see a color and I can see it's increased, and I'm looking in somebody's throat, I can see that's redness. When I palpate, I can feel a lymph node and its size is increased. Patient can tell me they've got pain in their throat. The temperature or the heat that I measured, I can say that was 38.9 centigrade. I can detect white counts, and I can see hemolytic colonies growing on an agar plate. And then I apply inference to those things, and I can say, oh, that redness and other things, and the cervical lymphadenopathy, that represents inflammation that's going on. And that's a positive strep culture based on how it grew. And the temperature is actually a fever because it's persisted for the right. And I've got an increased white count. And so that's first level inferences. And then you can take those things and you can put it all together and say, oh, based on those things, I can make this higher level assertion that this patient has acute streptococcal pharyngitis. And then if I take that and tertiary, I add in some other information about the fact that they had a splenectomy and they've had recurrent infections of this kind, I can say, oh, this is actually an immunocompromised patient. The points that I would make from this are that the closer that you can start to that primitive data and distinguish between the primitive data and the inferences that you're making from the data, sort of the better off you are. You want to be able to do all of this, by the way. This is critical that we be able to do all of this. But if you can get the data at primary source, if somebody just tells you that the patient is immunocompromised, you could theoretically think about some of these other things that existed down in the lower levels, but it would be very vague and you would be on uncertain ground in doing that. But if you get the data itself, there are a bunch of things that it allows you to do. The same primitive data then can be used to make many different inferences. Okay? You can do quality assurance on your inferences. You can apply a different or better diagnostic algorithm and be able to provide better medicine as that works, or create better knowledge. You can create better ways to create the inferences. You can move from Boolean logic to neural networks and AI and all of those kind of things. And you can create new inferences from old data. The higher you get up in the chain, you lose the detail and the capability to do those things. So that's just something. It's just me being stupid because I like this diagram. So thank you very much, and I'll stop there. And I guess we have time for a few questions.
So I thought this time I'd move round. Yeah.
Just feel free, Charles.
You tell the assembled horde that we're going to do questions in the room first.
So we'll go around in the room for questions first, and then I'll keep an eye open for ones online. But feel free to question away.
So Laszlo.
Thank you very much for a very interesting sort of logic which you took us through with why interoperability is important. My question is related to, you made that comment that we are making mistakes by selecting the wrong test. And that's quite a common thing. If you have got 960 odd ways of asking for a test, you have got 960 odd minus one way of getting it wrong. Is there any mileage of trying to make these systems simpler, yet clinically significant, or somehow get away the decision making on the test type from the requester and giving a bit to the pathologist who in normal circumstances do their onions well?
Yeah, there are a bunch of things. So I mentioned, the livid strategy, so you can have the people who are making the test kit say this is the right code to use, if you're using this test kit or this instrument and this reagent or whatever. That's one thing you can do. Another thing that's actually pretty helpful is if you could actually see what everybody else is using. So, it would be like 1 star, 2 star, 3, like when you go looking for a restaurant, you go, it comes to the top and you go, oh, well, everybody else is using that one. That's probably, a good idea. But the other thing, the longer term, is that you change the paradigm. So, the company that I'm working with, Graphite, and there are others who are doing this, so I don't, you actually go out and you say, look, let's get a group of people together. Let's assume that we're using FHIR, we're using LOINC, we're using SNOMED, and you actually make a model and it's constrained to the way that you want it done. And that settles the question of pre and post coordination. You say, look, here's one and only one code that you use when you're doing, a glucose, and you say, and you put the method over here. You don't use the code that has the method pre-coordinated. You don't use the code, that has some of the other information. And so when you're now building software and sharing data, what you do is go out to a library of preferred models that tell you exactly how to represent that clinical finding. And that's the way, that's hard. That's really hard, because the amount of data that we're dealing with, that means you're going to have tens of thousands of models, because you've got to say, how am I going to represent hematocrits? How am I going to represent white counts? How am I going to represent deep tendon reflexes? How am I going to represent echocardiograph findings? How am I, but that's the only way I know of to get to really plug and play interoperability. That's not today, but that's the path to go to. You're welcome.
Thanks, Dan. Have we got any other questions in the audience? Okay, in which case, Ian, I'm handing over to you.
Okay. So I'd like to thank Anna Rasander, who know very well for her very longer question. So are you ready for this? Regarding pre and post coordination, many of the new concepts for pathology are heavily post coordinated. What are the ideas within SNOMED regarding this, which I guess isn't just you to answer that one? And will separate, less pre-coordinated concepts be made? If someone asks for them, will they be allowed, or is this just the way SNOMED is going? For example, the example they give here is presence of estrogen receptor in malignant neoplasm of breast by immunohistochemistry as an observable entity. And then what's that? Whoops, they are pre-coordinated.
I don't know that I can predict what. I'll make a guess. I think they will become less pre-coordinated. You know, that again, bringing the information model into perspective, that would be represented by multiple records in the patient's electronic record. One that describes you know, the clinical finding of a mass and the fact that you took a biopsy and then the biopsy results, which and a separate record for saying what the receptor testing was, the hormone receptor testing. So those would be separate records. And again, that's kind of that idea about getting closer to the primitive data. Because if I have all of that as discrete data, I can reason about it and I can reuse it. I can do all kinds of things with it. And so I hope that's the direction we go, but it's going to be determined by all of us, you know, in the audience about what we want to do.
Oh, okay. Stan, are you prepared to have an answer from?
Well, yeah.
As well. So thanks, Stan, and thanks for tolerating me. Is that a pre-coordinated term, or do you need to make a special one for tolerating me? Because I think it's special. Anyway, so first honest question, and it also supports your question. So the term Anna is referring to is something very, very specific to a very specific test that's agreed upon across the world, and that would be estrogen receptor staining in breast cancer. And that's been very well agreed upon among the pathologists. And we want to make sure that, and as the Cancer Synoptic Group was moving forward, one of our charges was to make sure that that question and answer pair were completely independent of their context, and their meaning would be completely maintained once the registry removed that piece of information from the protocol or the instrument of data collection. And that was very, very intentional. But to your point, it would have been very inappropriate for us to make a bunch of very, very, very specific observables that would bring into that same question the reagents that were used, the particular, you know, antibody cocktail that was used, how well the receptors reacted to that antibody. The information model handles that very, very nicely, and so should it. And it's an agreed upon information model. So yeah. To your point, Stan, it's always a balance, and the use case oftentimes dictates the direction.
No, you're exactly right. And I didn't want to misconstrue that you don't. In fact, I think my example might not have expressed the whole thought, and that is those things that we infer become knowledge for the next level, because the next thing you know, they're going to say, you know, if the patient is immunocompromised, then something. Well, you don't want to have to go back and recalculate and determine whether this patient is immunocompromised. If you do that once, you want to record that in the record. And so, you know, a bunch of complicated things went on to classify that breast tumor, and so it's perfectly valid then, once you've done that, to record that, because that now is the basis for chemotherapy and other kinds of, you know, treatments, or whatever the treatments are. So I think we're in perfect agreement. But, you know, there are those situations, but then there are situations too where we're actually not any better off to have pre-coordinated them. We could have just left it as knowing the results of each of the individual tests.
So you heard it here first. Two terminologists can agree.
Hey, Stan, Jay Kohler. Sorry, I'll stand. Just reflecting on your slides reminds me of something that Alan Rector, my mentor, used to say around exactly what you said. Use cases, hierarchies are use case specific, right? We've put so much effort into building good hierarchies. We still get it right or wrong sometimes. But you also touched on the solution to what Laszlo was asking, forms, right? So Alan Rector always used to say, Jay, Larry Weed's conclusion or one finding was that you can only build so many forms because there is always one other form to build, right? And I'm being very cheeky here, but because I when I look at you, I think with your experience, is there a balance between getting the pre-coordination and the post-coordination? Because when somebody mentions forms to me, I just look at it and say, a lot of it is post-coordination built into a form, right? And your slide had this beautiful sentence, which is, it would be possible or be useful to have a library of reusable pre and post-coordinate expressions, was your colleague's observation.
Mhm.
Same thing that we did in the NHS 10 years ago. What do you think is the way to get to that reusable library? Because if we could get to that reusable library, we might be able to satisfy the people who want everything pre-coordinated and the use cases, I'm not saying people, use cases which need to be post-coordinated or broken down. Do you think it's possible, and where do you think that could exist?
It's totally possible. And I mean, we have the technology to do it. And we're doing it already. And, SNOMED with the expression language and that, that's the technology we'd use to do it. So having said that, the real issue is who's going to fund it? Okay. Yeah. We got to find people to fund it. We need to explain it. We got to make better slides than I've got. You guys can understand this. I presented this to people in Congress. They would go, what the hell is Stan smoking? I mean, and so somehow so again, not being smart. We've got to figure out how to simplify what we're saying in a way that they understand the value of funding something like that. And unfortunately, it's not as easy as explaining a fly swatter. Ultimately, it is that people are going to live better lives, and we're not going to kill 250,000 people a year from preventable medical errors. That's the kind of thing that comes out, but it's a long enough chain that we just have to get really good at explaining it to people in a simple way that it makes sense. I thought, the plenary speaker about, our future health, we need him to talk everywhere, and provide money so that we can do these things.
So that's a great point just to stop. There's a challenge for you while you have a bit of coffee to think about the slide set that's going to help Stan convince the congressman to put some money in. We can all play into that. There's also a message from Frederick Treves that says, go next door and refresh your appendix, I think it says there. So about 10 minutes, please, just to have a cup of coffee, have a quick chat, and then back here for our two final speakers. So thank you all very much. And you probably want to instruct the people online what to do.
So for those online, we're just going to take a quick 10-minute break. So we'll be back at 3:10 UK time, or 2:10 UTC, or whichever time zone you're in. So hopefully go and get a drink, and we'll see you in a while.
Thank you all very much. You all right with that? Am I meant to switch this off? Or no, I just leave? Yeah. Still got 66 on? We've got 66 people on. That's good. So no walking, Thomas.
Okay.
Really? You can look at.
So a minor change to the order. Can I introduce James to you all? James is a professor at King's College Hospital. Actually, over the last few months, we've collaborated, haven't we, James, on ideas around how one might use free text records to develop structured data for then computational analysis, and obviously the use in twins, not surprisingly. So James, welcome, and thank you very much for agreeing to speak.
Okay, thank you, Charles. It's been a pleasure. I must confess, as with all these things, you get a bit of imposter syndrome because I am not a pathologist, I'm a neurologist. We don't do that much pathology, but a little bit of it. And I actually come into this via a different path. I come into it through the natural language processing route and the AI route in informatics. However, I'm very, very much believe in the idea of structuring the data and code the data in high quality content. But I think I have a slightly different approach to addressing it rather than using synoptic reports and such. Some of this is driven perhaps by my background as a neurologist, in which I did my PhD in motor learning and training human behavior and measuring that and reflexes. And I have learned to a certain extent it's very hard to change human behavior and very hard to get myself as a clinician or my colleagues or my staff to code data accurately all the time, because that's not their primary job. Their primary job is delivering care. So I'm just going to talk a little bit about how we've been exploring language AI to support the delivery of coded structured data. So the way I like to think of it is that we all live up here on the surface, trying to get the iceberg bit at the top above the water, codified and structured using the EHRs and vendor systems. We wanted to codify it. We want it to be represented in a good ontology with which is sufficiently expressive and standardized. But the reality is, certainly in many hospitals that I have worked in the UK, a lot of the data is actually in that dark bit, the scary deep ocean bit, where you have all kinds of documents and all kinds of free form formats, text documents, even PDFs of emails, email chains even, and images. Some of them obviously radiological and some of them histopathological perhaps. All that large amounts of data, by and large, are relatively hard to source. It's relatively easy for a human to pick up one of these documents and read them, but it's not very computable. And we think that this direction may change in the next few years, that this data may be computable. So we've actually originally set up with this network called the CogStack, which is our open source platform, which we have released to a number, deployed in a number of NHS organizations, and also other organizations have jumped on board and used our open source code, and we have a number of sites around the country. And in this approach, what we've done is largely organically grown up from either local departments or enterprise-wide. So certainly at King's College Hospital and Guy's and St. Thomas's and UCLH, it is enterprise-wide, as well as South London and Maudsley Mental Health Trust, but some of these other trusts are only departmental. And we have deployments in Netherlands and Australia as well. But at this stage, it's a consortium rather than necessarily a network, perhaps. Well, it's a network, I guess, rather than a single entity. What is it? So essentially, all that structured form data on the far left up there with the forms, that's all the codified data that we traditionally collect. But there's all these kind of other data, the PDFs, Word documents and such, which some of it is generated from the coded data, but a lot of it is free form. We ingest a lot of this data into a modern technological stack, and we keep them in this technological stack, which we use is called Elasticsearch, which is a non-SQL database, which essentially indexes the data to make it searchable. It handles free text. It scan documents, we run OCR across it, and it just generates it into a text. And then that initial lake, the CogStack bit, we then start deploying NLP on top. So the first bit of the lake, the free text bit, allows us to do keyword searching, which has all its advantages and flaws. It's not particularly AI. It's just Control F to find a word or phrase. But obviously, there is a lot of functionality we can already do with that. We can obviously find phrases. We can find serial numbers of devices and things like that if we wanted to. And this provides a lot of functionality. And we link that with all the structured data like geospatial data, as well as useful codes and pathology reports and numeric data. And the bit that I want to talk more about is the language AI bit, which within our platform we call MatCat, which is a tunable system. So this essentially is what kind of a simplified summary of what we've been trying to do. All that data going into one place. And then we use a number of machine-supported processes to try to put it all into a big, massive unstructured lake in which we use AI to process and clean and sort into a more computable format. And that more computable format would be ideally, we've been working towards this SNOMED, and it can also obviously feed further research registries and databases. So I'll show a little bit of it. So for example, this is just a demo of a site. In fact, I think the link up there works. If you use the QR code, it's just a web portal. You can type in a bit of free text, and it pre-labels the various concepts. We train it to detect not just the concept, but also the context of it, whether it is mentioned in the presence or absence of, or whether it is misspelled. As you know, you can see the breathlessness is perhaps misspelled, and we can detect these phrases as well as synonyms or jargon or abbreviations, and this process is tunable. So this is this model that the web demo has is what we call a semi-supervised label model, which is only been trained on itself. We haven't marked it yet. A human hasn't marked it yet. But the human marking process trains the model. And this human marking process, we have been training for some time. So these codes are there. Yep. Okay. So whatever the case, this is an early untuned model, okay, which hasn't been trained yet, but already has some degree of performance. This task in the NLP world is called named entity recognition, where it means it detects one of these, I think Stan mentioned the primitive data concepts and then attaches it to a meaning, and then we can start to build and compose more complex concepts from that. So the training process, we have an interface called MAGCAT Trainer, which someone goes in and marks it. And it basically pre-lit that first semi-supervised label, highlights the bit of text, and then attaches it to a particular SNOMED code, or ontology, and the context with it, and then a human marks it whether it's correct or wrong. So that the red bit at the top is where they mark it as detected the word discharged as discharged, and that and the human marks that is correct or wrong. And then subsequently below that, the green area is where they mark the context. Is it mentioned? What does it mean? The semantic context, whether it's mentioned this person was discharged now, or this patient was discharged later, or this person's mother was discharged, or this person's was not discharged at all. And so this meta annotation bit teaches the grammar and context of it. And we have been doing this in large bulk, and some of my members of my team are here from Guy's and St. Thomas's and King's, who essentially engage large numbers of clinicians, analysts, nurses to help this process. We've published on this in which we've taken a model that was trained in one hospital, King's College Hospital, and brought it to another hospital, essentially like a UCLH or the Maudsley Hospital, and then tested its performance there in detecting those phrases and the context around it. And across a broad list of SNOMED terms, the accuracy is pretty good. So that little red boxes there is what we call the F1 score, which is a combination of positive predictive value and sensitivity. And 1.0 is a perfect match, and 0 is a complete mismatch. And as you can see here, if you train it at KCH and you test it in KCH, the performance is very high, 0.947, whereas it drops if you take that model down and bring it to another hospital like the Maudsley or UCLH, the performance drops, but then is rapidly retunable. If you just show it a little bit of additional documents, mark it a bit, and then the performance rises up again. Now, obviously, this number, this 0.947 number or 0.95 number, is an oversimplification, because obviously there are thousands, hundreds of thousands of concepts in an ontology, and these are only the ones that it has seen and we has marked. And it may be that there are many other concepts that its performance is actually very poor in, and for that poor concepts, we use a large amount of fine-tuning. So essentially all those marking of individual words, we have been doing that with staff. So either clinical coding staff, registry staff, essentially logging into a web portal, looking at the record and checking if a particular word matches a particular concept in its context. And we actually started this during the pandemic. Actually in March 2020, I personally started doing this myself because we needed huge volumes of data about our COVID patients, about their phenotype, about what presentations, what symptoms, what examination findings. And being a new disease, we didn't know most of this. Not all the codes necessarily existed at that point. And so we needed to capture this degree of fine-tuning at scale. With 60,000 different validations, we are training all its performance gaps. So this is an example of each of these rows is a SNOMED concept in which the performance, perhaps initially on the column on the far, the second farmost column, the initial performance, the F1, just next to the red arrow, the performance was initially very poor. It was 0. That means it missed up all the terms of renal dialysis. But then after, perhaps the renal dialysis is very poor, but it jumps very quickly to 0.977 with 1,000 markings. But let's say some other code like nausea or vomiting, you can see you need substantially less marking to produce a very high performance. And this annotation process, we call it, it can be stored and it can be used to tune the model, and so that a master model will become much better and better over time. And we've been doing this at scale so that we can produce a master language model which can process unstructured data to feed other things. So the thinking around this is, let's say in digital pathology, you may have images, source data, genomic data, but you also have the reports that are, some of them obviously perfectly designed synoptic reports, but most of them are not. And we have the huge history of them. We have 20 years of these completely unstructured documents. We can use our NLP to derive structure from it, and that structure would be standardized in a SNOMED ontology or a LOINC ontology, and then be fed subsequently to other machine learning, clinical decision support, analytics, or AI development. And so the thinking really is that we are using AI not for care. We are using AI to do the really tedious part of data management and processing. This video probably doesn't work. It's just disappeared off there. But essentially, what we've also been doing. Sorry, I think apologies to the people up online. There is a video on this, but it's not showing. But essentially, the video just shows the marking process, and essentially, it's just basically click yes, no. Is it correct? Is it wrong? What the context is? Can you suggest an alternative SNOMED code and such? We are also in the process of developing building relationship maps between the concepts. So if someone says there is a polyp in the colon, but there is no polyp in the rectum, then we can, a traditional approach, you wouldn't be able to tell whether the presence of the polyp is in the colon or the rectum, but with these relational maps, we are able to pick up that grammar. And then the idea being that it would be able to distinguish the anatomical localizations. But not only that, we can also, as you can see, we've introduced other grammatical concepts like, does something happen before another thing or after another thing? Is it just a renaming of the same thing? We thought it was originally immunosuppression, but it's turned out to be a more specific term, which is, let's say, a particular kind of immunodeficiency. And so all this is so that how the processing of the data can be handled in a more automated fashion. Now, oh gosh, it's come up now. I should have just pressed the green button. Oh, no, it didn't play, but never mind. The idea is that the concept is there, is that this is a bit of free, anonymized free text in which, as you can see, certain terms have been highlighted and we try to map it out in terms of their relationships. And essentially a human just marks whether they're correct or wrong. And if it's correct, it's marked blue. If it's wrong, we mark red. And essentially that helps train the algorithm to detect, to pick up the relevant, to link it to the correct SNOMED concept. So a particular patient may have hundreds of different concepts attached to them, but these are generated algorithmically, right? And obviously many of them may be, some of them may be wrong. This is a probabilistic issue, but we can have statistics on the degree of accuracy. We have also used this for the identification of text. So the same approach can be used in which we can label certain words as names and certain words as identifiable data. So, classic scenario, diseases who are named after people like Smith syndrome or Parkinson's disease. If Mr. Parkinson ends up showing up, he will end up not being de-identified, or vice versa. And so what we are training it to do is that to train it to recognize when a particular phrase is a name or an address, based on the surrounding words, so that a human doesn't actually need to read and redact them manually. Because we can do this at scale now, we can take one of those trained models, AI models, and run it across everything. And we have done that. We have taken one of these models. Many of these codes may not necessarily be accurate, but there's maybe 90% of them are accurate perhaps. And then we can run it across everything in our trust, in our organization, over 1 million patients, over 20 years. And then we can generate very high dimensional maps of these people. So essentially each patient may have 100 different codes attached to them. Some of them disease codes, some of them disorder codes, some of them finding codes, some of them situation codes. But each patient will have thousands and thousands of dimensions. And these are the kinds of things which modern day neural networks are designed to handle. And we can start to cluster them into groups based on their similarity. And so we've clustered patients into groups of 100, just to show that how we could do it. The meaning of these clusters is obviously very difficult to interpret at this stage, but this is, I think, the direction of travel if you want to look for, let's say if you get a particular patient coming in and they say, oh, can you find me a record of an NR patient who's similar to this one? What happened to them? What was the diagnosis and end? All that can be generated this way. But this is only possible if you had huge amounts of deeply phenotyped high-dimensional data, which NLP processing allows us to do at scale. We can obviously link this with coded, clean, nicely sorted, perfectly entered coded data as well. I would say that knowing my generation of clinicians, I think it would be very hard to generate a huge volume of that. We have started to map this out onto knowledge graphs. So you can obviously, as previously been described, a particular patient may have lots of different primitive data points attached to to them, but they're attached to them at different documents at different time points. And we can generate a particular patient may have 100 documents, and their mention of cancer may be in 12 of them, but their mention of rectal bleeding will maybe in another 6 or 7 different documents. You can attach this into really complex knowledge graphs, which conform to a SNOMED ontology or any other ontological hierarchy. And we have described this, and we have released the code to do this. And so so as you can see on this graph, for example, these pretty pictures that we generated with a graph database. The red circles are a particular disease concept mapped within a hierarchy. The blue bits are documents referring to a particular patient, and the green is a patient. So you can look for all the documents which relate to a particular concept, or how the patients who have X number of concepts together or in relation to each other. This obviously becomes a much more complex computational task, which we are only at the foothills of. So all this work we've actually done over a long time before language AI became the trending thing with ChatGPT. We started actually with the 100K genome project. We were at that point, the 100K genome project was needing help with recruiting patients without a final diagnosis. And well, good luck finding that in a coded database. So what we decided to do was to ingest the data to search for these undiagnosed patients, and from there we grew. And so we have a number of sites around the UK now, and as you can see, as we progressed, the natural language AI field progressed very rapidly on the with the green arrows below. And we began to kind of deploy a lot of this technology and test this technology out for handling large volumes of data. And we have been funded by the NHS AI Lab and Health Data Research UK and a number of other major funders to build these things so that we can process data, and so that the data, good quality data, is no longer at a bottleneck. In our trust, we have begun to reinsert some of these codes into legacy systems. So many of this is a particular EHR system. What we do is we find all the patients who have the relevant SNOMED term from their free text, find if in their they have that in their problem list, and if it doesn't, well, we have a double check, then we can reinsert it in. But we have begun to do that at King's College Hospital to improve the quality of our structured data. And we add there's a final human step in which when a clinician clicks on the record and it sees this suggests this code, we say, we think this person has this condition because he mentioned it in a letter from 2008 that he has this condition. Do you accept? Put it into the record. And so this produces the final human step so that we're not introducing bad data with good data. But this, I think, will allow us to leverage a lot of the old data formats or lack of formats into the new modern data formats that we are all trying to achieve, so that we don't have to climb the mountain from the bottom. This is just another one on a UCLH site in which we are beginning to explore to suggest these codes as we type in real time. Using integration, and again, so that it can not just pull things from the problem list, but can push things back into the problem list, vice versa. So all this is so to make the process of producing good quality data, good quality standardized data, a lot easier for the person entering the data whose primary job is to see the patients, not enter data. This is stuff which we have. This is something that I'm quite interested in right now because of the ChatGPT space. But this is not necessarily directly related. But all that high dimensional data that we have generated, they are all plotted in time. So a particular person may have a cough, or they may have a date stamp attached to that document. We can arrange that in time, like all these concepts, like words in a sentence. Now, if you trained a language AI to try to complete words in a sentence, so these concepts in a sentence, you can actually build some sort of autocomplete for a patient's life. So you can forecast what likely next concept might appear in their record. So in this, for example, that timeline up there, that someone has ketoacidosis at a particular age, diabetes mellitus at a particular age, various other conditions, chronic kidney disease. Then we feed this thing to what we call MetGPT, and then it gives a suggestion. We ask it, can you suggest a disorder or finding or medication? And in this case, and then it can also look at which bits of its history it thinks is most relevant to that particular suggestion. And this suggestion can be tuned accordingly as well, like as we know with ChatGPT and such. And we actually released this MetGPT into 2021, but we thought it was a toy rather than anything useful. And we certainly don't think it is ready for clinical decision making. We don't. It's not. We're not building this as a medical device at this stage. We are still. There are too high a risk of suggesting wrong things, or too high a risk of suggesting things which are no longer relevant in practice. So if guidelines change, then it may be suggesting old practices which may be outdated. So we should not think of this as clinical decision support, but as a simulation of what happened in real world. But the advantage of this simulation is that this simulation is completely imaginary and can be used for virtual trials or digital twins, as others have mentioned. So this would be a digital twin of a person, of a patient's record. I think the videos and all don't work, but we have, there's a YouTube link. We have begun to demo it. We've got an early demo from last year, which you can go just log in and just input yourself. You can input free text, or you can input SNOMED codes in a time sequence. We have been continued to train this so that it more accurately represents medical knowledge rather than just clinical practice. But the whole point is that we are only able to do this because we have the structure of codified data to support it. Not the free text. The free text has to be converted into codified data, structured data, and that structured data can then be used to generate inferences. And we are trying to do a bit of shortcutting of the process by avoiding needing doctors and clinical staff to input large amounts of free text and tick boxes and such. So we're kind of in the, how should we say, in your terminology, the trying to convert post-coordinated to pre-coordinated concepts. Gosh, sorry, the green button did. And so we're open source. We have source code on GitHub. We've got contacts. We've got discussion boards. It's a big international community building this, and we have obviously industry partners, including NVIDIA, to help us with the AI components. So that's my presentation. I'll happy to take questions or comments or criticisms either.
So thanks very much, James. There's lots of hands going up. So
Malcolm Duncan, I picked up on one word which fascinated me. You just skipped over it: deduplication. Lots of letters where I saw this nice patient with heart disease in clinic today, and elsewhere it says angina pectoris or something. Is that what you are?
That is one kind of deduplication, which is a renaming of the same thing.
Yeah.
But there are some very simple deduplications in that doctors and nurses copy and paste a lot. And there's a lot of texts which are just identical between letter to letter or note to note. And you can be deduplicating that in itself is important.
But you do actually use the SNOMED ontology to say, oh, well, angina pectoris, therefore cardiovascular disease.
We are building the tools to allow that deduplication to occur. So that relational bit that you saw, so that we can mark this as this is just a renaming of the same thing.
Yeah.
But to distinguish that from two identical things happening.
Yeah.
Because it may be that the angina, there were two episodes of angina pectoris, not a single one. So that the tool to train the difference between the two is things that we are training for, tuning the AI for.
Okay. Thank you.
Thanks.
Thank you very much. It was really fascinating. I'm a pathologist and not a neurologist, but the AI and all of these things are fascinating. Have you used it in the setting of digital pathology or imaging yet?
So I'm part of an AI center which is involved in what we call machine vision. The machine vision element of it is largely radiological at present because we don't have a large amount of digital pathology images. We built there's a framework called Monai Label, which we set up with NVIDIA, which creates a structure, a software framework for labeling images and attaching labels to them together with this. So the same labeling process that you see here for text, there is a software framework that we are working on for labeling images.
It's very interesting because we are going in the roughly the same direction. With my son, we created a technology which was very much akin and probably built on the same GPT architecture to create dynamic coding as I am dictating the report and linking that data to the coordinates and magnification of the digital pathology slide. And I think there is a lot of things which is usable for this one because yes, we, like yourself, have got data since 1989 medical records on histology, and data mining is one of them, is important. But to look forward into the future and SNOMED code these things on the fly, I think will be the real deal.
Yeah, I think that would really make everyone who's delivering healthcare's life a lot easier. I think it's just a question how we deliver it, and you can, as you say. Others, I think in an earlier talk, talked about, what if you had 100 different possible codes? The clinician is not going to necessarily pick the correct one. And so we have to build some tools to do some of that sifting. Obviously, you can rank it, but if, let's say, it suggests it based on the most likely codes first, then it's likely to be an AI-driven process.
And also into the right clinical context, because I believe the data is worth as much as it's inside the context. And that's why I think it's important to get it back into the image where it does belong to and store it together. And that's what you can use for next gen.
Yes.
But thank you very much.
I don't see any other hand. Ah, so sorry, missed you.
Thank you. I'm from the Netherlands, and previously I've done research with more or less the Control F version of like getting data out of records for studies. And this looks very good, but I was wondering, well, how easy would it be for us to use it with another language and another system?
Yes, so we actually have a good collaboration with Utrecht, and Utrecht have been training a Dutch NLP with it using the same tool set, because obviously the Dutch language, I don't know anything about the Dutch language, but obviously other languages may have very long words but conjugated together in all kinds of accents. And so they are doing tuning on that as well. A number of other UMCs around the Netherlands have expressed interest in further deployments. We can obviously pick up the conversation later, but I would say that you can obviously download the tools off the internet right now. The AI models for the training is the laborious bit, to train it to be accurate enough. You can obviously train it yourself. We obviously would be happy to lend the help, or to at least to your Dutch neighbors for them to lend the help of the work they've already done, because it's likely that the language in one hospital in Netherlands is identical to the language in another hospital.
First of all, thank you for the fascinating presentation. Just something that came with my mind just now. I get crazy ideas sometimes. How feasible is it to combine a Coq stack, Open EHR, SNOMED CT, IPS, and GPT-4 or GPT-5 when it does come live, in your opinion? It's more like an open question. Right?
Fortunately, it's your last question.
All day. It is, everything is feasible. The question is to do it. It is hard work, and obviously, as we know, many of these very, very large language models are closed. They're not open AI, they're closed AI. And so they are trained by big tech for generic use. Healthcare use is probably needs some specialized knowledge. I appreciate, I know that many of the ChatGPT and such do okay in some healthcare aspects, but it probably doesn't link that well to SNOMED perfectly very well at this stage. I suspect there is a whole domain of tuning these AIs, a whole industry of this that's going to spring up over the next decade. Linking them all together and doing the integration is a huge effort. I mean, I've got members of Anthony Shack in the corner, Joshua, a huge number of people trying to work on the integration of different systems. It is hard work, and it requires a lot of funds and willpower to sustain yourself through this. But doable.
That's great. We're going to have to move on, so you'll have to connect afterwards. But James, thank you so much for a great presentation. You've got his website, so if you do want to follow up, do so. I know that James is very responsive because I've tried it myself. So we are now down to our last speaker, so I'm very, very pleased to introduce you to Thomas Rüdiger, who is part of the SNOMED community, chairs the Pathology CRG, and over to you.
So thank you very much for inviting me. So I'm giving a bit of a change of perspective. I want to speak about how to use or implement or trying to use SNOMED CT in a surgical pathology laboratory. Just for Scott, down the red point is where I'm living. We discussed it previously. So just as a quick introduction, I'm head of the Pathology Institute with 10 pathologists and about 50,000 cases. Due to the German system, I am personally responsible for all the diagnoses that are signed out. And for this reason, I have worked a lot on standardization, intra and inter-observer reliability, and on assuring comprehension of clinicians to our reports. So the German language is quite of a problem for natural language processing, because people try to have double or triple negation together with conditional phrases. So this is very difficult even for people to understand whether they mean yes or no. And it depends on the region. So if you are in Bavaria, so you have double negation as no, and in other regions as yes. However, so to view pathology as a black box, which is turning a specimen on the upper left to a report on the lower right, to think what is happening inside pathology, and probably not all of you are pathologists. This is a quite complex process, which where the specimen flows and is worked on until the report is signed out in the end. And I've been working on laboratory automation and on this process for the last 15 years. And during that time, I learned something about the principles of lean. So lean comes basically from the car industry and is invented by Toyota. And what they were thinking of is basically the value is defined by the customer. So produce in your report what the clinician wants or what the patient needs. And the interesting part is the value stream. All steps which are not needed to have this final value desired by your customer is called waste. And this is generally 9 out of 10 of the steps you're doing. I never believed it until I tried in my own laboratory, and it's really so you're processing, you're putting there, you're taking away, and all these things you're describing a lot in macroscopy, what you don't need later at all. And if you try to bring this towards perfection, you probably become better and better with your work in the laboratory. If you look at this seminal paper of Ellis and Strigley, it's probably the using lean on the requirements of a report. So they say, okay, it has to be consistent and clear to the clinician. It has to be complete and accurate. The timeliness is something of the workflow perspective, and it has to conform with current agreed standards. And they define 6 scales, and level 1 is the narrative report, and level 6 is what we all wish in a way, the level with terminology binding to SNOMED CT and other reference terminologies. What is interesting is in the lower part, where they define what they think who is helped by implementing one level or the other. So the clinician is helped from level 3 on, and the pathologist from level 4. And in the end, you have secondary user needs, which is basically the cancer registries and epidemiologic studies. If you look at our reports, when I came to the hospital in 2007, we had narrative reports which were different to read and understand even to me. So I had to assign all these reports, and it was 200 reports in an hour, and each of them had on average 3 pages. So I just signed, and I never knew what was in the report. So I quickly changed to synoptic reports, which is what we are currently having, and we are now trying to go to a kind of structured report where software leads us through the diagnostic process. And this is the one where I just tell the company, okay, I want SNOMED codes behind each and every of these parts, both the question and the answer part. And at that time they said yes, which was quite optimistic. What we are currently having is a level 4 synoptic report, which because we have these drop-down menus behind, which do some of the coding, and if one of the fields is used twice or more times in the report, it's all coming from the same field. So we are struggling towards consistency, as long as nobody tries to fill in the form by hand. And if you look at the paper again, what my experience is when you go from one level to the other, it changes a little bit what needs are fulfilled. So I think clinicians are happy with the synoptic format, and currently, as long as they just read the report, they don't need any more. So they don't care whether you used any electronic reporting tools or terminology binding or things. So pathologists are helped by electronic reporting tools, but it's an increasingly hard effort to go into higher levels to implement ICCR datasets, because they are only 95% identical to German guidelines. So you have to do all the others. They are probably also 95% identical to the RC Path guidelines. So we all have some. So it's all highly similar, but not the same. The main thing in level 6 is it helps public health. So cancer registries are really helped by an effort which should be done by an individual pathology or individual. So to look how the report is built up, I just changed the workflow scheme to show you the 3 points where probably information is generated. So the first is grossing, when we have a macroscopic piece of tissue, then reading at the microscope, and if the diagnosis is malignant, we usually do predictive studies, which are done by molecular biologists or and in the next gen laboratory. Let's start with grossing, and now you have to think in SNOMED a little bit. So you have this piece of tissue, which is a segment of breast. So the green form is what the clinician tries to tell us. So how it's labeled. So the length of these surgical threads of the breast tissue convey some information. Also the cork, whether it's on the cork or off, and this is how we get our information currently. And what we are trying to do is to fill in the right side in a structured way. What we are then doing is a point which is very important, because we are destroying the specimen. So we are just leaving the integrity of the specimen. So this can never be reconstructed after cutting it. And we are also inking the specimen to convey the information on orientation to the histology slide. And then we have all these slices of the tissue, and on this we can measure the tumor on the right here. So you can measure the size of the tumor in at least in 2 dimensions. The third dimension you have to estimate, and you can measure all the margins. This is information which is given by the at the grossing room, and which may be confirmed or may be challenged later in histology, but usually this information is quite correct. And if you look at the ICCR sheet, you see that a large part of the sheet is just information from grossing room, and this no pathologist wants to re-enter into a form after making a diagnosis. So when we think of what does it mean to terminology, we first of all have the macroscopic measurements, which may be overridden by microscopy. So if you think of the distance of neoplasm from surgical margin, and so on. So probably you need to have subconcepts measured macroscopically or microscopically, or you post-coordinate this. What we also need is concepts that help us to define specimen orientation and both the clinical margins and the ink we are using. And not to have an exploding number of concepts, you need probably something what I would call post-coordination patterns. So how the information is linked to define margins, to define orientations. And what I found interesting this morning is the question of value sets. So specimen to grossing. So in what specimen, what pieces of tissue will you have in grossing? But this could be done by an association ref set. Additionally important, so many of you talked about image analysis when reading digitally. To automate this, you probably need to know for each and every slide what specimen or what part of a specimen is on it, what organ is it, do you expect a tumor, is it a margin, is it a lymph node region? This decides what AI should be running on the slide. So it doesn't make very much sense to run a prostate carcinoma detection on lung tissue or so. And you also need to know what stain it is, because you may want to count Ki67 by Ki67 index, but then you need a slide stained with Ki67, and it doesn't make sense on the others. And this all should be done before the doctor is reading it, so he should already have all this information. Next step is reading the slide at the microscope. So this is basically what the pathologists do. And at that point, we go so at the grossing, we had the organ, now we have the histological tissue on a cellular level. And the method we are working with is also to go down to the protein level. So the proteins which make up the cells are detected by immunohistochemistry, and you can also, with in situ hybridization, see some of the genetic changes. So ancillary techniques have to be used to come to a diagnosis in pathology. And so if we want to use the forms not only for cancer resection specimens, but to implement it into our workflow, so we need biopsy forms which allow us to document non-malignant diagnosis. So if malignancy is suspected but not confirmed by the pathology, we should have a possibility to use this in the forms and to have a structured report even on that. And what is one of my interests is inter and intra-observer reliability. So we have spoken a lot of doctors being 50% right. So this is some problem we also have when we are doing if we are grading cancer. So this is, there are sometimes very structured models how to do it. But if you don't have the picture in hand and you are a general pathologist or you're not expert in the theme, you may have some variability. In addition, it would be helpful to have an electronic access to knowledge resources like WHO or like the different kinds of TNM staging, and also PubMed would be nice to have in SNOMED CT to look. And for ancillary techniques, we need strategies. So there are several hundreds of antibodies which can be used in different use cases. And again, as we already spoke about the data to complex for humans to keep in mind. The problem is most of the antibodies are positive in some percentage, but never in 100%. So you never have a yes or no answer. You always have shades of gray in your answers. And this could be helped, I think, with by decision support systems. And from a terminology point of view, for that, we basically need to go into immunohistochemistry to model all these. I'm sure Scott is almost ready with it. But in the international browser this morning, there were only 31 concepts, observables under the immunohistochemistry group. So we need many more without including the different techniques and so on and so on. What gave me a hard time is when I asked the vendor to make all the forms SNOMED or to code all the forms with SNOMED CT, was that acinar adenocarcinoma of the prostate, one of the most frequent cancers in males, does not yet exist. So the problem with the gaps is that to implement it, it will not be enough to have 95%. Because people will come and say, okay, there's something missing, and so on. And we also need implementation of UICC and, as I said, on PubMed, and probably a language or an association between to business rules should give us the ability to model complex relationships between knowledge sources. One more thing which is interesting for us is something I call a disorder concept. I've learned that this can be patient pathways, longitudinal picture, or disorder lifetime in other nomenclatures. What it says is that we often have a context for a patient. So we see a patient more than once. If he comes up with a disorder, we start with a biopsy. There we make a diagnosis on it. And after that, if there's surgical treatment, we get frozen sections, we get a resection, we may get a marginal resection later. And this all builds on the already known diagnosis and just extend the model. And so it is with predictive markers and with relapses, which may or may not come later on, but to have a knowledge, not to just to list all your reports, but like you showed, to say, okay, this patient has diseases 1, 2, and 3, and let's go on. And it's also interesting with chronic diseases like chronic inflammatory bowel diseases, which also have their sequelae, which it's easier to know when you read the slide. So last one is predictive pathology. You have heard some of it. Is the information relevant for individualized medicine? So we try to figure out which pathway is involved in cancerogenesis, and so which drug will likely be effective. And depending on the age and the stage of the patient, you have first to decide which genes to analyze if you're not at a university and you can analyze everything just for research interest. And then once you get the answer, you have to do a clinical annotation to see which drugs have been approved for this entity and stage, whether the mutation you found is druggable. So this is a real challenge, and I think it also would be helped by a lot by terminology. And we have already talked about interoperation between pathology, which is also the middle, but not the only discipline for or treating a patient. So you have to think of pathology in a context, especially with other diagnostic specialities, but also with clinical specialties. And if you want to think of interoperation, you can take even more variables into account, even disorders which may not be diagnosed by a pathologist. And what would be interesting to see in an integration between different specialities, to see which one is most efficient in finding the origin of a primary tumor, depending on also the price, but also on availability of different investigations. So whether our immunohistochemistry telling the origin of a tumor or an MRI taken by radiology will be better, safer, and so on for patient. And in this interoperation, I could imagine graphical elements in a report. So in the upper left, you have a very short, very structured report, but still in the right, the graphical element may be easier to grasp what to do with the patient or to understand it. And these all also could be connected by SNOMED CT by using different attributes and quantitative measurements that could all be then graphically shown to the clinician. And as a pathologist, you don't have to see this graphical because you see the slide itself. So Germany is very behind with structured reports, but our friends in the Netherlands, Palcha, have already investigated the barriers and facilitators to implement a structured workflow. They found some barriers, which first of all is nuance. So whether you are sure or not so sure about your finding, this is very difficult to see in a structured report. However, I'm not sure whether clinicians want to have too much of the nuances. They just want a diagnosis from us. Whether we are, so how sure we are is our problem in a way. And there's an interpretation step, and this needs to be traced, how the conclusion was made, by whom the conclusion was made, who's responsible for it. And the re-entering of data was their major problems. Facilitators are that your clinicians are happy, and those epidemiologic secondary things of information retrieval. And what they showed is that compulsory templates made people to use other templates later once they had to do it. But the use of guidelines was, I think, only 90%, also 100% of pathologists said they are in favor of these guidelines. By adding from my experience, I would say one of the facilitators is tumor preparation in my institute. So we just know we have all the data. But barriers are still within SNOMED CT. So some gaps we have to fill. Some of them are easy to fill. Some will require some larger effort. And what will come up for us is that the content which is not current or not maintained, which is like the map to ICDO, which is not in line with the current WHO classification. So if you want to add one more level to the workflow, as workflow support as level 7 for the eHealth, I think workflow support could help clinicians, pathologists, and public health, and in the end the patient, because on an individual level it will make better reports, which will later be better to be explored for epidemiologic studies or for research. And in the end, I think SNOMED CT might be able to be the common language for different systems, which will be linked to the laboratory information system, both image management, order entry, and structured reporting with additional parts. If they all use the same language, which you can discuss with different companies, each doing their strength and being able to build an interface. Thank you very much.
Perfect timing, Thomas.
Thank you.
Very, very interesting, really inspiring, I think, about how we could do things differently in our laboratories. Are there any questions? There must be one from Laszlo.
Of course, there is. It's not a question, rather a comment, because I really liked your way how you put all of these things on the patient. You know, just watch it, pathologist, patient, okay? That's an important thing. And I think the level 7, which you showed me, I think that's where we want to be. And if you mean in the workflow, the patient timeline as well, which you integrated, I think that's the 7th heaven. When you have got everything for the patient, what you need, you get the clinical data, you make your decisions, use all of the tools of the tool chest, you are able to collect the data from PubMed and decision support systems. You know, I will not retire. That's it. You know, pathology is interesting again. Thank you very much, Thomas. That was really great.
Thank you.
Great comment, thanks. Any other questions in the audience?
We have one question online, so I hope you're all sitting comfortably, because it's a long one. So are pre-analytical data before pathology interoperable, encoded for surgical and collection procedure, specimen type, timing fixative, specimen source, etc., and pre-populating for anatomic pathology LIS synoptic fields and reports for pathologists to finish with their exams? I'll stop there, there's more.
Okay.
Comment on that first before, because it's going to go on a bit.
No, I would like to have this data. So it's not always important, but sometimes yes. So you should not process tissue before it's fixed long enough, and this would help me.
Okay, and it's got
part.
and then shared reported. Then shared reported data discreetly encoded with downstream systems. So basically feeding back to EHRs, KIS systems, registries, oncology systems, research systems. So from your presentation, it looks like not yes. Realizing also that there are differences between countries and practices within those countries. Our anatomy, I think this one's particularly more applicable. Our anatomic pathology LIS systems interoperable with all LIS systems, particularly for ancillary and marker testing and genomics LIS systems.
It's a long question.
I didn't say it was short.
Okay, so we don't have all the concepts in SNOMED CT to get the pre-analytical data and to record them, but this is part of the work we will probably be doing. The second is pathology systems are not yet very interoperable with other systems, at least not the ones I know. That's why in the last slide I also showed that the LIS system for me is somehow the center of everything and is basically dealing with patient data and billing and getting the report to the clinician, back to the clinicians. And the structured reporting is probably not done by the same vendors. It was, at least in my opinion, in my experience, these are newer, smaller companies building up this structured reporting. And the laboratory information system vendors usually have a hard time in just keeping up with the regulations and so on. I think that's, did I miss out any important part?
I don't think so.
Thank you.
I agree. I think you've covered most of the ground, Thomas. So I think we're at the end of our afternoon. Thank you all so much for sticking with us. I think we've had a really great afternoon, actually, and our three speakers have sort of covered a very wide range of thinking, of doing things, of connecting up those questions about how we make our systems genuinely interoperable, genuinely usable by other doctors in the system, other nurses, but crucially going to Laszlo's point, in the end, making something that is usable by the people we look after. And I think that is an enormous prize to be had, and one that we should all be aiming for. So I think Thomas was inviting you to the Pathology CRG, should you be interested. So join us. We meet, I think, sort of monthly or 2 monthly, and every 2 weeks.
Well, for cancer, yeah.
Wow.
For cancer.
Very intense. Yeah. Well, those Nebraska guys haven't got enough to do. It's living out in the mountains. There's just nothing out there, is there? Right. I'm going to hand over to oh, my brain's gone.
Okay, so well, I'm going to do a bit here. Then I'm going to shoot back to my laptop for one bit, which isn't on the slides, but I'll do that in a second. So this is obviously when we meet formally like this, either in London, so this time of year, or in October, which I'll tell you about in a second. We do these extended webinar sessions, but in between times, we also run some other online web series, so online webinars. Myself and Charles focus on the first one, which is obviously clinical, but my colleague Susie Roy heads up one around research, so bringing researchers from around the world. And increasingly now we're doing more implementation-focused web series. We promote these both on our website and also on social media. So if you see something that interests you, please come along and join. You know, it's coming around very quickly. These things always seem to come around a lot more quickly than we think. It's not that far away now from October and our expo in Atlanta. We have the call out for abstracts, or even abstracts, for abstracts. So if you want to put an abstract in, or you know someone that does, then please do.
May 2nd was not what you was on the slide set you guys set out, which is correct.
Extended deadline, so May the 2nd. Right? Right, and for this particular session, so on the all the clinical engagements things that we do have a home, if you like, on Confluence. I can never remember the link to the Confluence, so I had a chat with Rory and we now have a short link. So if you just go on www.snomed.org/clinical, it gets you to this page. And I've put a news item on here with a link which takes you to the page for this series of presentations today. So all the presentations are on there, and shortly the recording, a link to the recording, will also be on there. So I'd like to thank you all for your attendance, both in person and online. And I wish you all well. And if you're here in person, we have a closing plenary now. And for those online, go and put the kettle on. And thank you very much.